Uh, Good morning.
Good morning.
As
Good
part
morning.
of our coverage of the text in surgery, today we will have a presentation on stomach. So we are starting with a basic anatomy, physiology of stomach. The first speaker will be Dr. Shayandi from Ramakrishna Seva Pratishthan, who will speak on gastric anatomy. Shayandi, you can share your screen and start presenting.
Okay. Good morning, everyone. Am I audible?
Yes, you are audible. Share your screen.
Yes, yes.
Third speaker is second. I'm speaking on next. Shandeep, your screen was shared. You can turn off. Shandeep, you are muted.
Yes, sir. 1 minute. 1 minute, sir. 1 minute.
Yeah.
Okay. Sir, is it
No, not
visible,
yet.
sir?
No, it is not visible. You are audible. It's visible. Shandeep, you can start.
Good morning, everyone. Today's topic is surgical anatomy of stomach. Good morning. Yes. Introduction. Stomach is a dilated J-shaped hollow portion of alimentary system in continuation with esophagus superiorly and duodenum inferiorly. The parts of stomach are cardia, fundus, body, pyloric part, divided into pyloric antrum and pylorus. There are two orifices present: cardiac orifice guarded by lower esophageal sphincter and pyloric orifice guarded by pyloric sphincter. Now, structure of stomach. Stomach wall contains all the four layers of alimentary canal, namely the mucosa, submucosa, muscle layer, serosa. The mucosa of stomach is thrown into multiple folds called rugae. This differentiates it from rest of the alimentary tract. The mucosa contains gastric glands, which secretes gastric juices required for digestion. The muscle layer of stomach contains three layers of muscular coat, namely the circular, longitudinal, and oblique muscles, which makes it unique from rest of the GI tract. The oblique muscle layer helps in proper mixing and churning of food in stomach. This is a diagram depicting the parts of the stomach, the defined parts, as well as the four layers of stomach. Now, the structure of gastric glands. Gastric glands are located all over the stomach mucosa. A gland consists of mouth, neck, body, and base. The epithelium is formed by different cell types, which are discussed below. There are numerous gastric pits in mucosa to which gastric glands open up. 3 to 7 glands open into one gastric pit. The different cell types are: first, the neck mucous cells. These are columnar epithelial cells located mainly at the neck of the glands. They are responsible for secretion of mucus that is important in protecting gastric mucosa from autodigestion. Stem cells, these are different undifferentiated cells situated between the neck mucous cells. They give rise to other cells when replacement is required. Opsentic or parietal cells, these are large oval cells with central spherical nucleus present mainly in the mid and upper region of the glands. They produce hydrochloric acid required for digestion as well as intrinsic factor required for vitamin B12 absorption. The secretions of these cells are primarily regulated by histamine, acetylcholine, and gastrin. Cheap or peptic cells, these are the most numerous cells. They are present mainly at the base of the glands. They secrete pepsinogen enzyme. G or gastrin cells, these are present mainly at the middle portion of the glands. These cells have centrally placed nuclei that differentiate it from other cells. They secrete gastrin and work in conjunction with chief and parietal cells. They are innervated by vagus. Now, the vascular supply of stomach. Firstly, the arterial supply. The arterial supply of stomach mainly arises from the celiac trunk, which is a direct branch of abdominal aorta. The main arteries are: along the lesser curvature, there is the left gastric artery arising from the celiac trunk and gives esophageal branches that anastomoses with the right gastric artery along the lesser curvature. The right gastric artery arises from the common hepatic artery, supplies mainly pylorus of the stomach, and it anastomoses with left gastric artery. Along the greater curvature, splenic artery divides into short gastric arteries and left gastroepiploic artery. Short gastric arteries run upwards and supply fundus of the stomach. It may sometimes arise from the spleen material. It is a source of bleeding during greater curvature dissection. The left gastroepiploic artery runs inferiorly along the greater curvature and anastomoses with right gastroepiploic artery that arises from gastroduodenal artery. The posterior gastric arteries. They arise from splenic artery and sometimes from left gastroepiploic artery. They may be absent in few persons. Ligation may lead to posterior wall necrosis. Now the venous supply of stomach. Venous supply of the stomach along the lesser curvature, the left gastric vein and the right gastric vein anastomosis along the lesser curvature with both drains into the portal vein. And now along the greater curvature, the short gastric veins draining blood from the fundus of the stomach comes and joins splenic vein. Inferiorly along the greater curvature, the left gastroepiploic vein drains blood and joins the splenic vein as well. The left gastroepiploic vein anastomosis with the right epiploic vein, which drains into the superior mesenteric vein. At the pylorus, there can be an anastomosis between branches from right gastric vein and right epiploic vein at pylorus called pre-pyloric vein of Mayo. This acts as a landmark for identifying pylorus of stomach. In this picture, there is the venous supply of the stomach is depicted, and on the right, the pre-pyloric vein of Mayo is being shown. Now the nerve supply of stomach. Stomach is supplied by both parasympathetic and sympathetic parts of autonomic system. In the parasympathetic nervous system, the anterior and posterior esophageal plexus gives rise to anterior and posterior vagal trunk respectively. The anterior and posterior vagal trunk give rise to anterior and posterior gastric divisions respectively, which in turn gives rise to hepatic pyloric branches and celiac branches respectively. Both the anterior and posterior gastric divisions gives short nerve branches to lesser curvature, which are called the nerve of lateral jet. The branches end in a fashion known as crow's feet. This is a landmark for identification of antrum of stomach on the lesser curvature, which is usually 3 to 4 centimeter cranial to it. Now there is the criminal nerve of Gracie. This is the first branch of posterior trunk supplying the fundus. If it is not divided during surgery, it may lead to recurrent ulcers. Now, vagotomy. There are three types, mainly the truncal vagotomy, when both anterior and posterior vagal trunks are cut; selective vagotomy, when the anterior gastric division is cut after its branches into the hepatic and pyloric branches; and superselective, when the nerve branches that supplies the lesser curvature are cut. This is the parasympathetic supply. Now the sympathetic nerve supply, the preganglionic fibers mainly from the thoracic branching nerves, that is T6 to T10, and postganglionic fibers arise in ganglia of celiac plexus. Now the lymphatic supply of stomach. The lymphatics of stomach follows the arterial supply arteries of the stomach. It is divided into four zones. Zone 1, inferior gastric nodes around right gastroepiploic and gastroduodenal arteries to nodes around the hepatic artery to celiac nodes. Zone 2 is the splenic, nodes around the left gastroepiploic and short gastric arteries to pancreatico-splenic nodes to splenic artery nodes to celiac nodes. And zone 3, that is the superior gastric nodes around the left gastric artery to celiac nodes. And zone 4, hepatic, nodes around the right gastric artery to celiac nodes. Lymphatics around lesser curvature along the left gastric artery are the largest, as it drains almost all the lesser curvature and a large portion of body of stomach. Gastric lymphatics are continuous with esophageal lymphatics at the cardiac orifice. They play an important role in the spread of cancer. It can spread to the liver by portal vein or by reversal flow of lymphatic vessels from liver to the pelvis by retroperitoneal lymphatics, and other parts of the body by via veins or indirectly via thoracic duct. Below is the diagram of the Japanese classification of the lymph node stations of stomach. These lymph node stations are important while performing gastrectomy during gastric carcinoma, and the D1, D2, D3 gastrectomy are done by the and are differentiated by the number of lymph node stations that are lymphadenectomy that are done. And finally, the ligaments of stomach. The gastrosplenic ligaments attaches to spleen and greater curvature of stomach. It contains the short gastric vessels and left gastroepiploic vessels. The gastrophrenic ligament attaches fundus of the stomach to diaphragm. It sometimes contains short gastric vessels. Maximum part is avascular, giving bloodless dissection behind esophagus. Lesser omentum by hepatogastric and hepatoduodenal ligaments. It contains the hepatic triad found by biliary ducts, portal vein, and hepatic artery. And finally, the gastrocolic ligament of the greater omentum along inferior surface of the greater curvature of stomach. Thank you.
Okay, Dr. Dash, you can have just few questions on this presentation.
Sandeep, so
Yes, sir.
the better arrangement of when you are telling anatomy, if first
sir.
the external anatomy and the gross anatomy first, then
Okay, sir.
artery, venous, lymphatic supply, and finally the this microscopic anatomy. It is usually in that order.
Yeah.
Okay. Regarding microscopic anatomy, can you describe some surgical importance or important layers? You have described this just here mucosa, and what is the important layer of mucosa that differences between the invading gastric carcinoma and non-invading gastric carcinoma?
If you go by anatomy, when do you call this is an early gastric cancer, and when you say invasive gastric cancer?
Sir, when the submucosa is not breached.
Yes, but
Mucosa and
actually the
submucosa.
deepest layer of the mucosa, this muscularis mucosae, is very important.
Muscularis mucosa, yes.
Yes, that differentiates between the invasive stomach and though it is and surgical part we check as the submucosa because we submucosal dissection are done in early gastric cancer. Again, okay, and which is the strongest layer among these all these layers of the stomach? Again, submucosa is the strongest layer.
Okay.
It gives most strength of the stomach wall. And among the muscular layers, which is the strongest, which is the most well formed? It is the circular layer of the circular muscles are strongest and is continuous. It is very useful for gastric motility.
Yes. Okay.
And regarding arterial supply,
Yes, sir.
what are the major arterial supply?
Sir, the major arterial supply are the left gastric, just like the ones I have told. They are derived
Yes.
from the celiac cancer. And along with the left gastric artery,
Is there okay? Other
yes,
than
sir.
these arteries, any other small vessels may supply stomach?
Small vessels
From above. The inferior phrenic artery is an important artery. It may supply the near the upper end of the stomach near gastroesophageal junction. You have to mention this.
Okay.
Inferior phrenic artery may not be supplied always, but there are a number of in a get percentage of the persons you will get the inferior phrenic artery.
Inferior phrenic.
Careful when yes, when you are dissecting in the gastroesophageal junction.
Okay, sir.
And another important factor when you are ligating the left gastric artery during malignancy, where you ligate usually, where is the ideal way of ligating the left gastric artery?
Close to stomach.
Yes, yes,
Close to
you
the
are
stomach.
right. It should be very
Not close to the stomach.
origin.
Close to origin.
It is close to be origin, but
Origin.
what problem you have to may face? You have to be very careful. Any anomalies there? Is not very rare. Actually, left hepatic artery may originate from the left gastric artery, and you have to be very careful. If you ligate close to or proximal to that left part of the liver, vascular supply may be damaged.
Will be
damaged.
Okay. Okay.
Okay, there's time is short now.
Okay, another important thing, Sandeep.
Yes,
what
sir.
is the specialty about the stomach blood supply? Is there a specialty in the stomach blood supply? How is it? Is less vascular, very vascular?
No, sir. The vascularity is means
Stomach
very
is
vascular,
very
sir.
vascular, number one. And if you are doing some surgery where you need to take the stomach as a tube, it is said that you can ligate all the named gastric vessels and stomach will survive. How? You have ligated all the named gastric vessels. Stomach may still survive. How? What is the supply that can keep the stomach alive? You got my point? You can ligate
sir.
all the named vessels, but still stomach will not get infarction. Because in that case, stomach can derive its blood supply from the intrinsic vessels coming from the esophagus.
Okay.
So,
okay, sir.
Stomach is such a vascular structure, but it can survive even on ligating all the vessels. And while describing the nerve supply, some was very important. You see, stomach motility disorder is an important disease.
Yes,
where
sir.
you can explain this motility being controlled by vagus parasympathetic, and
Yeah.
apart from this, what else control stomach motility? Apart from the nerve?
The hormones, sir.
Yes, these hormones, these are all important.
Yes,
and in the vagal supply, it has been identified that there are two distinct type of vagal supply. One is gastric inhibitory vagal fibers, and one is gastric excitatory vagal fibers. Okay, this you
Okay,
see
sir.
in between, while patient is taking food, in the digestive phase, stomach is static, is not contracting, and food is not getting emptied immediately you take the food. The stomach has to be in a relaxed state when you're taking food. And in
Okay,
the
sir.
interdigestive period, stomach start churning the food, and
Yes, sir.
then it gets emptied. So there should be a balance between these excitatory and inhibitory fibers. And
Yes,
after
sir.
food, this humoral factor comes in, because these are all important for surgical point of view, where you need to know these basic things.
Yes, sir.
Okay.
Okay,
I think we can proceed on
Sandeep,
the next. Yes, Dr.
Sandeep,
Das, anything
another
else?
important thing, what is
Hello.
Yes, Dr. Das, please.
Nerve supply, terminal nerve of Gracie.
Yeah, he talked about
Sir,
that.
that is the first branch of the posterior trunk, sir. I
And
told, sir.
point is,
I
this
mentioned
can arise little higher up.
higher
The
up. Yes, sir.
peculiarity is, if it is arising at a lower level in truncal vacuum, this takes care of. If criminal nerve gastric comes little higher up, in that case, even truncal vagotomy, this nerve will be spared because it's coming little higher up from the posterior vagal trunk.
Yes, sir.
So that is a specialty of criminal nerve gastric, that this criminal nerve gastric can branch out earlier and then go to the fundus of the stomach. So you need to take care whether there any branch from the posterior vagus which is arising little higher up, which will be
Yes.
above the level of truncal vagotomy level.
Yes. Okay, sir.
So the next two part will be the physiology of stomach, physiology of gastric secretions, and gastric motility physiology. So that will be dealt by Dr. Milind Alokji, who is a third-year resident at MR Bangur Hospital. Milind, you can share your screen and present.
Good morning, sir. Is my screen visible? Is my screen visible?
Yes.
Yes,
Good
visible.
morning, sir. Good morning, respected teachers and my fellow colleagues. I'm Dr. Milind Alokji, and I'll be talking about the physiology of the stomach. Now, the principal function of the stomach is the preparation of the ingested food for digestion and absorption. And related to this is the physiology of the stomach. And what I'll be talking about today is the gastric secretion, the gastric mucous barrier, gastric motility, and gastric emptying, the physiology related to these. Now, if we see the digestion of the food, we see that in the initial part, from the esophagus, the food bolus comes into the stomach, and here is where the role of the stomach comes, where it prepares the food for further digestion and absorption. Now, this process is undertaken by there are three parts to this. That is, firstly, there's the storage of the food in the stomach for several hours. There is mechanical breakdown and there is biochemical breakdown. Now, when we talk about the storage for several hours, the initial part is what is known as the receptive relaxation of the proximal stomach. That is the proximal portion of the stomach. It relaxes in anticipation of the food intake. Now, the liquids pass easily along the lesser curvature, whereas the solid food settles in greater curvature of the fundus, and the passage of the solid food is controlled by the antrum. The antrum pylorus function together to allow the food entry into the duodenum and to return the unprepared food back into the proximal stomach. The next part is the mechanical breakdown. Now, this is responsible for the mixing and the grinding of the ingested food particles. And how this happens is that there is repetitive forceful contractions of the mid portion and the antrum portion of the stomach, which causes the food particles to be propelled against the closed pylorus. And this food particle basically between the mid portion antrum and the closed pylorus, the mixing, the grinding of the food takes place. And the net effect is that the food particles are broken down to less than 1 mm particle size. And the third part is the biochemical breakdown. The secretions of the secretions from the stomach, they are responsible along with the salivary secretions to break down the starch and the glycogen in the food to maltose, sucrose, lactose, and also the proteins in the fats are denatured to smaller biochemical compounds. Now, the regulation of the gastric function is under neural and hormonal components. Now, in the neural, we have the sympathetic and the parasympathetic supply as described by my previous speaker. And in the hormonal, we have peptides. Now, recently, it has been noted that there is a lot of overlap in the function between the neuronal components and the peptides, the neurotransmitters and the peptides, and therefore, a lot of them are referred to as neuropeptides together under the broad term. So here we see a list of the various neuropeptides that are there. The first function is the secretory function. So we see that there are different neuropeptides and peptides that stimulate the secretory and inhibit the secretion. So we have, we'll talk about them in detail. We have gastrin, histamine, acetylcholine that stimulate secretion. And then we have somatostatin, neurotensin, GIP that inhibit secretion. Similarly, motility is also affected by a large number of neuropeptides and peptides. Those stimulating motility include acetylcholine, histamine, gastrin, motilin, and those inhibiting motility include such as somatostatin, VIP, nitric oxide. Now we come to gastric acid secretion. Now, there are more than 1 billion parietal cells in the normal human stomach, and in response to a protein meal, around 20 millimole per hour of HCl is secreted. Each individual parietal cell secretes around 3.3 billion hydrogen ions per second, and there is a linear relationship between the maximum acid output and the parietal cell number. Now, the structure of the lumen has already been explained by my previous speaker. Now, here as he spoke about the different kind of cells, there are mucous neck cells which secrete mucus and bicarbonate. There are parietal cells which secrete gastric acid and intrinsic factor. There are ECL or enterochromaffin-like cells that secrete histamine, chief cells that secrete pepsinogen and gastric lipase, D cells and G cells that secrete somatostatin and gastrin. Now, this composition is not uniform across the entire stomach. In the body and in the antrum, they mainly differ. The D cells and the G cells are mainly concentrated in the gastric antrum, and they are functionally linked with an inverse relationship. We will talk about this in detail. Now, when we talk about the gastric acid secretion, we see that it is primarily under the control of three things. One is the acetylcholine that is secreted by the vagus. Second is the gastrin, and third is the histamine. Now, after a meal, we see that the vagus is stimulated, the parasympathetic supply, which secretes acetylcholine. Now, this acetylcholine acts on three cells. One, it acts on the enterochromaffin-like cells. Second, it directly acts on the parietal cell. And third, it acts on the G cell. Now, the G cell, it releases gastrin, which again acts on the enterochromaffin-like cell and also on the parietal cell. And the enterochromaffin-like cell and the central and the main pathway of the release of acid from the parietal cell is release of histamine. This will be just more clear in the subsequent diagram, but from this diagram, what I would like to point out is that the G cell and the acetylcholine and the histamine are the three main regulators. Now, the effect of the acetylcholine, the effect of gastrin here is through both endocrine function and paracrine function. That is, the gastrin that is released from the cells nearby to the parietal cells acts in a paracrine fashion, whereas those released from the antrum acts as an endocrine fashion. Now, apart from this, we have the role of the D cell. Now, the D cell releases somatostatin. The role of the somatostatin is to inhibit the ECL, the enterochromaffin-like cell, and also to inhibit the G cell. So the somatostatin, basically what it does is that it inhibits the secretion of the acid from the parietal cell. Now, through this diagram, I hope to make this a little more clear because it presents everything more clearly. Now, here as we see, now we start with the enteric nervous system. Here we see that the M3 receptor or the M1 receptor is the receptor for the acetylcholine. Now, here on the enterochromaffin-like cell, as we can see, it is getting stimulation from two sides. One is the acetylcholine, and the second is this G. This G is coming from the G cell, that is the gastrin. Now here it is coming, and this is releasing the histamine. Now here is the parietal cell. The parietal cell is again the three components as I mentioned. It is releasing stimulus from the acetylcholine, from the histamine, and from the gastrin. And in response, it is releasing the acid. Now, along with that, we see that this is the antral portion of the stomach. Now, the gastrin how is the gastrin stimulated? It is stimulated in response of acetylcholine 1, and secondly, in response to a digested meal. So when the food comes into the stomach, it is broken down into peptides. Now, these peptides, specifically peptides and the amino acids in the food, stimulate the G cell to release gastrin. When the pH of the stomach reaches less than 3, the D cell is stimulated, and this D cell will inhibit the G cell and will also inhibit the parietal cell and the ECL cell. So this is how the entire gastric secretion take place. Now, here I would also like to add a few lines about the various pharmacological interventions can be done here. Now, as you can see, here is where the H2 antagonists work, such as famotidine, ranitidine, and the anticholinergics work at the level where the ACH acts on the ECL and the parietal cell. And then we have the proton pump inhibitors such as pantoprazole and omeprazole. They work here at the level of the H plus K plus ATPase pump. Now, along with the gastric acid secretion, it is also important to understand the various phases of the gastric secretion, because the acid secretion differs depending on the phase. Now, first of all, we have the cephalic phase, which begins before the food enters the stomach, with the sight or the thought of the food, or when the food is in the mouth. Now, this basically acts on the brain in the cerebral cortex and the hypothalamus, which stimulates the vagus nerve. And again, the vagus nerve will release the acetylcholine that will lead to an initial 20 to 30% of the acid release. So in the cephalic phase, of the total acid that is released, only 20 to 30% is released in the cephalic phase. Then we come to the gastric phase. Now the gastric phase is where 60 to 70% of the total acid is released, and it lasts till the stomach is empty. Now this is activated by the distension of the stomach and also the food chemicals and the rising pH of the chemoreceptors. They again, the chemicals and the rising pH, they act on the G cell, which releases the gastrin, and the distension will stimulate the vagus that will cause the acid secretion by the ACH. Finally, we have the intestinal phase. The intestinal phase starts after the gastric emptying and continues as long as the digested food is there in the proximal small intestine. And this is basically, this releases 10% of the gastric acid secretion, and the intestinal gastrin, this is basically the intestinal gastrin that is releases into the blood, and it stimulates the stomach secretory activity. Now, a very short and very briefly, I would also like to talk about the intracellular events. Basically, most of these receptors, whether it is the histamine receptor or the somatostatin or the acetylcholinogastrin, they act through two secondary messengers, which is the CAMP pathway and the phospholipase C pathway, which activate protein kinase and the various other kinases. And the HCl is released via the H plus K plus ATPase pump and also the chloride channel. But the final common pathway is the H plus K plus ATPase pump. Now, since it is an ATPase pump, the energy requirement is so large that the largest mitochondrial content of any mammalian cell is there in the parietal cell. The parietal, 34% of the parietal cell volume contains only the mitochondria. Now this was the now, as we had seen in the picture earlier, this was the role of the parietal cell. Now we come to the role of the other cells, the other gastric secretions, first of which is the mucus and the bicarbonate. Now the mucus and the bicarbonate is their main role is that they together neutralize the gastric acid at the gastric mucosal surface. Now the mucus is basically a viscoelastic gel that is composed mainly of water. It is secreted by mainly by the mucous neck cells and also by the surface mucus cells, and these are present at the acid secreting areas and at the antrum of the stomach. Now the function is to provide a mechanical barrier to any injury, and also they stop the ion movement across the lumen. Now there is a constant state of flux because mucus is constantly secreted by the mucus cells also, and it is also constantly broken down. It is stimulated by vagal stimulation. The secretion is stimulated by vagal stimulation, acetylcholine, prostaglandins, and inhibited by anticholinergic drugs and NSAIDs. And H. pylori is said to secrete various proteases and lipases that break down this mucin and impair the protective function. Then we come to bicarbonate. It is secreted both by an active and passive process in different parts of the stomach, but the amount of bicarbonate secretion is considerably less than the acid secretion. Now the luminal pH is 2, whereas the surface epithelial pH is 7. But this gradient is still maintained because there is a large layer of unstirred water that is there. Now this will be, now here we see the gastric mucous barrier, and this will be a little, it will be easier to explain through this. Now as we can see, this is the layer of the pepsinogen and the pepsin where the gastric acid is acting. And here we see that this is the layer of the mucous bicarbonate barrier, mainly constituted by the mucus, which contains 85% of water. And the bicarbonate, it reacts with the acid, and it dilutes the effect of the acid mucosal barrier. Now to maintain the mucus bicarbonate barrier, only the role of the mucus cell is not there, but there are a number of important components that are also important to maintain this barrier. Now as we can see, mucus barrier and bicarbonate barrier are very important, but along with that, the microcirculation of the or the blood flow to the stomach bed is also very important. Now as we can see that why this stomach is very important, because this the adequate blood flow is important to provide the nutrition to the various cells that are producing this mucus barrier, and to ensure that any injury process does not affect it. As a result of which we can, now clinically if we see, this is important because in case of hypovolemic shock, the mucosa of the stomach takes the longest to come out from the effects of an hypovolemic shock. And therefore even in stress ulcers, the reason is this only, because the underlying circulation is affected, and that affects the mucous barrier. Also tight junctions are very important. Now here we see epithelial tight junctions. Now why these are very important? Normally across this gradient there is a potential difference of about -30 to -50 millivolt that is maintained, and whenever this barrier is affected, these tight junctions, because of the effect of the acid, are broken down. Now once these are broken down, the potential difference breaks down, and the other injuring factors such as NSAIDs and aspirins, which they are basically ionized, they become non-ionized at the low pH of the stomach, and then they are readily taken up by these cells which without these tight junctions they become lipid soluble, and they basically take up the NSAIDs and the aspirins, and the damaging effect of these drugs become more. Now, other gastric secretions include pepsinogen. Pepsinogen is the composition. They are basically proteolytic proenzymes, and they are secreted. There are two groups of pepsinogens, and they are basically mainly secreted by the chief cells along with other cells of the stomach. Their function is digestion of the protein. Why these two groups are important? Because group 2 pepsinogens are usually, they work over a larger spectrum of pH, and therefore even in the presence of a gastric ulcer, they are able to function. Then we have intrinsic factor. They are secreted by the parietal cell, and they are important for the absorption of vitamin B12. The secretion of the intrinsic factor parallels gastric acid secretion, and yet the secretory response is not linked to the acid secretion. So the chart that we had seen earlier, if we see it in a more broader way, we see that all these, we are now able to see that how the various cells, these are the substances that they release. These are the stimulus for these various substances, such as the mucus is the tonic secretions and the irritation of the mucosa. Bicarbonate is secreted with the mucus, and these are the various functions that the various cells of the gastric glands are there. And this in together is the whole chart for the cephalic, the gastric, and the intestinal phase. As we can see that it is not a very simple process, but a very complicated process that is linked. Next, we come to gastric motility. Now, gastric motility is under the neuronal control and myogenic control. In the neuronal, there is extrinsic factors such as vagal and the sympathetic, and intrinsic such as the enteric nervous system. In the myogenic, there are excitatory members of the gastric smooth muscle cell. Now, there are basically two components to this. Firstly, in the fasting state and the postprandial state, the motility is different. Now, in the fasting state, there are two signals. First is the electrical basis, which begins by the depolarization of the pacemaker cells located in the mid body of the stomach along the greater curvature, and these generate slow waves. These slow waves travel at 3 cycles per minute, and they are not associated with actual muscle contraction. Second is the stimulus that is related by the gastric smooth muscle cells that produce action potentials, which are associated with larger changes in the membrane potential than slow waves, and action potentials are associated with actual muscle contraction. These together function to produce what is known as the migrating motor complex or the myoelectric migrating complex. Now, the stomach goes through a cyclical pattern during the fasting gastric motility, and the net effect of this is that there is clearance of the gastric contents during the period of fasting. Now, each MMC lasts about 90 to 120 minutes, and it has 3 phases. The phase 1 is after the food is cleared, there is a period of quiescence, and which lasts around 40 to 60 minutes. Then we have in phase 2 where the slow waves basically start, and there are a series of slow waves with intermittent electrical waves, with intermittent rapid electrical waves. This lasts for around 40 minutes, and this starts from the fundus to the caudal direction at around 3 waves per minute, and they go as far as the pylorus but not beyond. In the phase 3, from the pylorus, the waves move into the proximal duodenum, and by the end of the phase 3, the electrical activity increases, is at the maximum, and this phase lasts for nearly 10 minutes. Now here, as you see, now this basically is the portion that is related to the stomach. This is here is phase 1, where there is a period of quiescence, followed by phase 2 and phase 3, where the electrical activity is the maximum, after which it passes to the proximal duodenum. Now, postprandial gastric motility is different. After the ingestion of the meal, initially there is receptive relaxation, that is the decrease in the tone, and the proximal part of the stomach relaxes, followed by gastric accommodation that allows the proximal stomach to act as a reservoir. Postprandial gastric motility is mediated by the vagus nerve, and the peristaltic activity in the antrum and the proximal stomach is tonic activity. As I explained earlier during the mechanical breakdown, the pylorus, which is usually open, contracts, and the pyloric and the peristaltic waves, they move the stomach, the food against this pylorus, and this causes the breaking down of the food, and the pylorus only arounds only a few millimeters of chyme into the through it into the proximal duodenum. And although the duodenum itself capable of generating up to 10 waves per minute, after a meal it only contracts after an antral wave reaches the pylorus. Now, although the exact mechanism of the gastric motility is not clearly understood, some factors that are that are important is, one, the action of the M cells release motilin, and the role of ghrelin. Ghrelin is one of the hormones that are related, and basically it is involved with gastric emptying. Now, it is postulated that in the migrating motor complex, the ghrelin and the motilin they initiate the phase 3, which increase the gastric emptying. And in the postprandial phase, it is the vagus nerve, and the vagus nerve which mainly maintains the postprandial gastric motility. And finally, we come to gastric emptying. Now, in gastric emptying, we see that liquids empty faster than solids, and carbohydrates are empty more readily than fat. And the modulators of gastric emptying, there are many factors such as osmolarity, acidity, caloric content, etc. Now here we see that if there is presence of improperly digested fatty food in the duodenum, or hypotonic food or acidic chyme, then this stimulates the duodenum to release enterogastrones such as CCK, GIP, and leptin. Also, they stimulate chemoreceptors and stretch receptors, which through various mechanisms delay gastric emptying. And this causes this delayed gastric emptying causes a negative feedback on the duodenum. Ghrelin, as I noted, is a hormone which causes increase in the gastric emptying. Now, liquid emptying and solid emptying are different. Very briefly, liquid emptying follows first order kinetics, and half emptying time is around 12 minutes. And this obviously changes with the composition of the liquid. There is an initial rapid phase and then a slow linear phase of liquid emptying. And generally, liquid emptying is delayed in supine position. When we come to solid emptying, the half time of solid gastric emptying is less than 2 hours. There is an initial, as against liquid emptying, there is an initial rapid phase. In solid emptying, there is an initial lag phase, and initially there only little emptying occurs, and this helps in grinding and mixing of the food particles. When liquids and solids are ingested together, the liquids are emptied first and the solids are stored in the fundus. As a result of which, especially in patients who are bothered by dumping syndrome, they are told to limit the amount of liquid consumed by the solid meal, taking advantage of this effect. As the larger solid component, or as the larger the solid component of the meal, the slower is the liquid emptying. Now, there are certain drugs that accelerate the gastric emptying, which we use a lot in clinical practice. So it is important to know, such as metoclopramide, erythromycin, and domperidone. Especially metoclopramide and domperidone are used to accelerate the gastric emptying. Thank you.
Yeah, Dr. Dash, good presentation.
I think Milind has covered everything. Nothing to add much more.
The important part
just
for
you may have mentioned some points regarding the gastroesophageal reflux. Just few points. What is the preventing mechanism of the reflux?
Yeah.
Otherwise, it is okay.
And another thing is when he talked of the what am I trying to say? Oh, that gastric secretion. There are, although now being not tested, there are some terms to understand the physiology of peptic ulcer disease, where you have a situation known as a definition called basal acid output. One is described as maximal acid output, and these two sometimes differentiate between a gastrin producing tumor causing peptic ulcer and other situation. What happens in gastrinoma? If you talk of basal acid output is what? Acid output over a basal condition over 1 hour. Maximal acid output is you stimulate the stomach by injecting gastrin and find the output in 1 hour in the two highest aliquot. Okay.
Yes.
So if there is a gastrinoma, what is the status about basal acid output and maximal acid output?
Sir, in case of a gastrinoma, sir, the gastrinoma, sir, they are unaffected by the injection, sir. Sir,
yes. In gastrinoma, basal acid output is extremely high because the cells are maximally stimulated by the secreted gastrin. So if you inject further gastrin, there will be no response. So basal acid output will be very high. Normally, basal acid is about 5 to 15 millimole per hour. Okay, so that is about gastric secretion. And then Dr. Dash was talking about the reflux. You see, reflux is again a combination of factors. It's a combination of factors. When the stomach contracts, it is supposed to propagate the food towards the pylorus. But there are some factors like the angle of his, the lower esophageal sphincter. So that can cause reflux. It's not an intrinsic stomach disorder. It's a disorder in the gastroesophageal junction. And that can cause reflux. And this reflux can occur in hiatus hernias and some situation where there is some abnormality in the angle of his, and sometimes with hypersecretion also. And some drugs can affect. Okay. And regarding the motility disorder, another important motility disorder is gastroparesis. You see, the stomach is contracting based on a combination of what you described is some excitatory fiber and some inhibitory fibers, because sometimes stomach need to be in resting state.
Yes,
and this combination of excitatory inhibitory stimulus causes the stomach to function. But there are some situations like some surgical situations where patient has got prolonged gastroparesis. This can happen following vagotomy. This can following some stomach surgery. This can be associated with diabetes mellitus. Very important condition for gastroparesis is patient having diabetes mellitus.
Yes.
So this is a clinical entity, and these patients, what are the symptoms? The patient having gastroparesis, what are the symptoms this patient may have? Some may be asymptomatic, but prominent symptoms are food is not passing out. So patient has discomfort,
bloating,
distension, sometimes vomiting.
Yes.
So the treatment for, you see, you have named 3 drugs, but sometimes all the drugs are not very effective. Even with these drugs, this gastroparesis may not be corrected. Okay, because it's a multifactorial. Otherwise, Milind has presented well. Dr. Dash, any comment?
Yes, another another important aspect you should have mentioned, that is the role of H. pylori to breach the mucosal barrier. It is an important factor nowadays. So you should have mentioned few points about this, how H. pylori breaks the mucosal barrier.
Produces
Okay,
urea.
that may be
Yes, it's producing
done in another
urease.
thing.
And again, H. pylori now is responsible for a number of changes in the stomach. It can cause gastric metaplasia, and then is one of the factor for developing lymphomas and CS stomach. We are not covering everything in one go. Madam, please.
Yes, that's
Madam has raised hand. Madam,
oh,
Madam Banerjee.
Good morning, Makunda
Yes.
and Dr. Dash.
yes.
What I wanted was, actually, Milind spoke so nicely about the physiology.
Yes.
We have two more entities which could have been covered: the upper sphincter and the lower sphincter, the cardiac sphincter and the pyloric sphincter. Because as Dr. Das was talking about the refluxes and the GRD, these sphincter mechanism and their anatomy and physiology covered up nicely would have been a better.
Madam, we have covered in the achalasia. We have last month. We have the esophagus as coverage. We covered the upper.
I have attended that class.
Yeah, that is actually
Right.
the upper sphincter is actually part of lower esophageal sphincter.
Esophagus,
It's not,
right? But sir,
and the pyloric sphincter he has talked of, where the pyloric sphincter remain in a tonic contraction, and stomach try to empty, the food is thrown back and it gets churned up. So pyloric sphincter is important because you see, pyloric sphincter is always present. It's not that pyloric sphincter is deficient. Pyloric sphincter has got a very important role for churning of food. It remains in tonic contraction during the digestive phase, and the food is being returned back to the stomach for churning. Again, yes,
okay.
these two
Okay.
are very important.
That
Yes.
was yeah. Okay, sir. Thank you.
Thank you, ma'am. Okay, we conclude today.
Thank you.
Tomorrow we'll have, I think, operative.
Yes.
Tomorrow we have operative discussion.
Thank you, sir.
Thank you.
Okay.
Thank you.
Thank
very
you.
much.
Thank you.
Good. President.